Hello everybody. Welcome to number 1 Doctor channel. Today we will talk about Epiploic Appendagitis. Welcome doctor.
Welcome to you and your channel subscribers.
Doctor. Epiploic Appendagitis, EA, also known as appendicitis epiploica, hemorrhagic epiploitis, Epiploic or appendagitis, is a benign and self-limited condition of the epiploic appendages that occurs secondary to torsion or spontaneous venous thrombosis of a draining vein. EA occurs most commonly in the 2nd to 5th decades of life. The mean age in several reports was approximately 38 years, and there was a similar incidence among men and women. Complete resolution without surgical intervention usually occurs between 3 to 14 days. Inaccurate diagnosis can lead to unnecessary hospitalizations, antibiotic therapy, and surgical intervention. Doctor. What about the anatomy of epiploic appendages?
Epiploic appendages are small outpouchings of fat-filled, serosa-covered structures present on the external surface of the colon projecting into the peritoneal cavity. The appendages are situated along the entire colon and are more abundant and larger in the transverse and sigmoid colon. Approximately 50 to 100 appendages are present in the colon of an average person. They are usually rudimentary at the base of the appendix. The epiploic appendages vary considerably in size, shape, and contour. For unclear reasons, they are largest and most prominent in obese persons and in those who have recently lost weight. The average length of the epiploic appendage is 3 centimeters, although they are occasionally up to 15 centimeters. They are presumed to serve a protective and defensive mechanism similar to that offered by the greater omentum. They may also act as a protective cushion during peristalsis. Each appendage encloses small branches of the circular artery and vein that supply the corresponding segment of the colon. Subserosal lymphatic channels either terminate in a lymph node within an appendage or loop through its base en route to mesenteric nodes.
Doctor. What about the pathophysiology of epiploic appendagitis?
Epiploic appendagitis, EA, is usually caused by torsion, which occurs when the appendage is abnormally long and large. The vein, which is longer than the artery by virtue of its tortuous course, alters the anatomy such that the pedicle is predisposed to twisting. Spontaneous venous thrombosis of a draining vein can also predispose to twisting of the appendage pedicle. Gradual torsion of the appendages can result in chronic inflammation with minimal or no symptoms. In contrast, acute strangulation is associated with the development of symptoms. Symptomatic EA can arise on any segment of the colon. The affected site was in the sigmoid colon or cecum in 75% of 156 patients in a retrospective study. In another report of 58 patients, the locations were the sigmoid 48%, descending 28%, transverse 7%, and ascending colon 17%. There are other less common conditions affecting the epiploic appendices. They can slide into a femoral, umbilical, or inguinal hernia sac where they may remain without causing symptoms or, less commonly, incarcerate with or without torsion. The appendices can also calcify, cast off, and lie free as foreign bodies, corpusculi, in the peritoneal cavity or become surrounded by omental adhesions. Epiploic appendages are thought to represent the most frequent source of intraperitoneal loose bodies, which are usually found in the pelvis. These may become secondarily attached elsewhere in the abdomen and can be confused with a neoplastic process.
Doctor. What about the clinical manifestations?
Patients most commonly present with acute abdominal pain. Symptoms can mimic an acute abdomen, frequently leading patients to be misdiagnosed as having acute appendicitis or diverticulitis. Appetite and bowel function are usually unchanged. Nausea and vomiting are rare. On physical examination, patients usually do not appear to be seriously ill and are afebrile. There is localized pain in the affected area, more often in the left lower than right lower quadrant. Rebound tenderness is usually not present. A mass is palpable in 10 to 30% of patients. The remainder of the examination is usually unremarkable.
Doctor. What about the laboratory tests?
Laboratory tests are useful for excluding other causes of similar symptoms. There are no pathognomonic diagnostic laboratory findings. The white blood count with differential and erythrocyte sedimentation rate are normal or only moderately elevated.
Doctor, how can diagnose the problem?
Epiploic Appendagitis (EA) should be considered in the differential diagnosis of patients presenting with localized lower abdominal pain without associated leukocytosis or fever. EA has been reported in 2 to 7% of patients in which a clinical suspicion of diverticulitis was entertained and in 0.3 to 1% of patients suspected of having appendicitis. The diagnosis should also be considered when exploration of the abdomen fails to reveal any of the more common causes in acute abdomen. When the diagnosis is not made before the patient undergoes surgery, the inflamed appendage is ligated and resected.
Doctor, what about the differential diagnosis in patients with epiploic appendagitis?
Abscess, appendicitis, colon cancer, or metastasis, Crohn's, ectopic pregnancy, gallbladder disease. Ilit is caused by infection with Yersinia, Campylobacter or Salmonella. Left or right-sided diverticulitis. Mesenteric adenitis. Mesenteric panniculitis. Metastases to the omentum. Ovarian torsion. Ruptured or hemorrhagic ovarian cyst. Segmental omental infarction. Urachal cyst.
Doctor, what about the radiologic examination?
Early radiologic examination with an abdominal computed tomography (CT) scan is key in making the diagnosis. This was illustrated in a retrospective study of 19 cases of EA presenting over a 4-year period in which a diagnosis was made by abdominal CT scan. Prior to having the abdominal CT scan performed, 2/3 of patients were suspected of having either appendicitis or diverticulitis. CT findings are virtually pathognomonic for EA while excluding other causes of abdominal pain. The appendices epiploica are usually not seen on CT scan unless they are surrounded by a sufficient amount of intraperitoneal fluid such as osteates or hemoperitoneum. The classic finding is a 2 to 3 cm, oval-shaped, fat density, paracolic mass with thickened peritoneal lining and periappendigeal fat stranding. A high attenuated central dot within the inflamed appendage that corresponds to a thrombosed draining appendigeal vein is occasionally evident. MRI findings of EA have not been well studied but appear to correlate with CT findings. EA can also be diagnosed on abdominal ultrasonography in both grayscale and colored Doppler, an approach probably best suited for patients with a thin body happiness seen at centers with experience in sonographic imaging of the colon. The inflamed appendage appears as a non-compressible, solid, hyperechoic ovoid mass with a subtle hypoechoic rim located at the point of maximal tenderness. The inflamed fatty mass is fixed to the colon and often also to the parietal peritoneum during inspiration and expiration. Doppler studies typically reveal absence of blood flow in the appendage. Contrast-enhanced ultrasound may be helpful to confirm the diagnosis of EA in equivocal cases when CT is not readily available. In a retrospective study of 15 cases of EA over a 2-year period, masses noted on contrast-enhanced ultrasound showed a central area of no enhancement.
Doctor, what about the treatment and complications of epiploic appendagitis?
Epiploic appendagitis (EA) is a benign and self-limiting condition in which the abdominal computed tomography (CT) scan appearance can lead to a confident diagnosis. Patients can be managed conservatively with oral anti-inflammatory medications and occasionally a short course of opiates. Anti-inflammatories provide analgesia, but probably do not modify the disease. Although there are no strict guidelines for therapy, we suggest ibuprofen 600 mg per every 8 hours for 4 to 6 days and Tylenol No. 3 acetaminophen/codeine 330ths every 6 hours as needed for 4 to 6 days. Most patients respond to these measures in about 4 to 7 days. Patients should be advised to seek medical attention if symptoms worsen after 2 days, such as with the development of high fever, progressive pain, nausea, vomiting, or inability to tolerate an oral diet. As a general rule, patients do not require hospitalization or antibiotics. Complications are uncommon. Inflamed appendages can adhere to the abdominal wall or other viscera predisposing to intestinal obstruction and intussusception. Inflamed and necrotic appendages can also rarely progress to abscess formation for which surgery is usually indicated. The risk of recurrence has not been described but is probably very low.
Doctor, Can you please tell us what is summary and recommendations for epiploic appendagitis?
Epiploic Appendagitis, EA, also known as Appendicitis epiploica, hemorrhagic epiploitis, Epiploic or Appendagitis, is a benign and self-limited condition of the epiploic appendages that occurs secondary to torsion or spontaneous venous thrombosis of a draining vein. It usually occurs when the appendage is abnormally long and large. Patients most commonly present with acute abdominal pain. Symptoms can mimic an acute abdomen, frequently leading patients to be misdiagnosed as having acute appendicitis or diverticulitis. EA should be considered in the differential diagnosis of patients presenting with localized lower abdominal pain without associated leukocytosis or fever. Early radiologic examination with an abdominal computed tomography (CT) scan is key in making the diagnosis and potentially avoiding unnecessary surgery. We recommend that patients with EA confirmed by CT scan be managed conservatively with oral anti-inflammatory medications and occasionally a short course of opiates, grade 1C. Most patients respond to these measures in about 4 to 7 days. Patients should be advised to seek medical attention if symptoms worsen after 2 days, such as with the development of high fever, progressive pain, nausea, vomiting, or inability to tolerate an oral diet.
Thanks, doctor, for excellent informations.
Thanks for you and for your channel subscribers.
Thanks for watching. Hope to see you again in more next videos. But please don't forget to like and share our videos and subscribe to our accounts in social media and links below each video. With my best wishes, Dr. Epiploic.